our NGOs and so many other societies like Pakistan Physiological Society, Pakistan Association of Pathologists, and Women Medical University, Allah Kare University ban jaye, Medical College Ahmedabad, and Azad Jammu Kashmir Medical College Muzaffarabad. And before starting this, today is the happy birthday of Quaid-e-Azam Muhammad Ali Jinnah, Baba-e-Qaum, sabko mubarak ho. May Allah bless this Pakistan, everyone here. And today is also happy Christmas. I will request Professor Rashid Saab to start with Holy Quran.
जज़ाकल्लाह सर। सर ये सूरह आल इमरान तीसरी सूरत है, इसकी आयत 145 है। और ये मौत के हवाले से कुरान मजीद में कई जगहों पर जिक्र है कि ये मौत अल्लाह के हुक्म से होती है। तो इसको थोड़ा रिसाइट कर देते हैं। औज़ु बिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम। वमा काना लिनफ्सिन अन तमूता इल्ला बिइज़्निल्लाहि किताबम मुअज्जला। वमन युरिद सवाबद दुनिया नुतिही मिनहा वमन युरिद सवाबल आखिरति नुतिही मिनहा वसनज्ज़ि शाकिरीन। मफ़हूम तर्जुमा है, कोई जी रूहुल्ला के इज़्न के बगैर नहीं मर सकता। मौत का वक्त तो लिखा हुआ है। जो शख्स स्वाब दुनिया के इरादे से काम करेगा उसको हम दुनिया ही में से देंगे, और जो स्वाब आखिरत के इरादे से काम करेगा वो आखिरत का स्वाब पाएगा, और शुक्र करने वालों को हम उनकी जज़ा जरूर अता करेंगे। सल्लल्लाहु अलैहि वसल्लम।
Jazakallah. Before starting this, the introduction of today's guest speakers, I welcome youngest principal, Professor Iqbal Hussain Dogar Saab. He has been appointed as a principal of Gujranwala Medical College. Hopefully, inshallah, Gujranwala Medical College will progress under your kind leadership. And also I welcome Professor Faisal Bashir, our youngest, and so many other stalwarts, Qazi Wasik Saab, and all the members of this one. It is very difficult to introduce Dr. Jasim Anwar. Very simply, Dr. Jasim Anwar is the youngest son of Pakistan. He graduated from the Ahmedabad and he did the PhD from the Sydney University. I also did the certificate program from the Sydney University. Beautiful building there. Dr. Jasim, no doubt the world knows about him, but the introduction that I am going to introduce, because few of the principals are sitting here, that he is the basic policy maker in the Kashmir. One day, my Secretary Health, Major General Hasan Wahid Sati, invited me in a meeting, and in that meeting, I saw a young man describing the important effects of the policy making in this one. And at the end, he was introduced me and the Jasim Anwar. From that day, Dr. Jasim Anwar is with me, and we have completed policy, and the policy is on the table of in the assembly, inshallah. Very hopefully. Thank you, Dr. Jasim. Another very important help of the Dr. Jasim to all the stalwarts sitting here. You can get benefit from Dr. Jasim Anwar, not only today's talk, but he was the very key person helping me in developing the university, first university, Kashmir University of Medical Sciences, that we have almost completed the act and everything with Dr. Jasim Anwar. Also, we both created the concept, and Dr. Jasim Anwar endorsed in the open policy making. And both acts are on the table of our assembly. Dr. Jasim, I think it will take me more than 1 hour to introduce. Now it is better to over to you to about the today's very important topic. Dr. Jasim Anwar, over to you.
Thank you so much, sir, for your introduction, and I'm very much humbled to be part of this session. Well, you all know that I am actually leading various policy processes in Pakistan. But the prime question, why I actually moved to this site was our project that we initiated in 2014, in fact. That was when I was chief of WHO, and we presented our findings of various surveys, Pakistan Demographic Health Survey and a few other surveys on mortality, maternal mortality, neonatal mortality, and infant mortality, and so on. And we were really much ashamed of the findings that we presented when we were supposed to meet the Millennium Development Goals by 2015. So I conceived a project. It's a big, large-scale project on measuring the mortality, and then looking into the factors that are actually neglected. So today's speak will cover two topics. Number one is mortality estimation in an actual scenario, what we did in a population of around 0.3 million, and what were the findings of that, and then the way forward that we developed in 2018 through civil registration and vital statistics. It's a NADRA and local government platform. And then followed by that, I'm proud to say AJK is the first province and the state as well to adopt this system through its policy. And Major General S.N. Sethi incorporated that information mechanisms for mortality estimation in real time. And I'm pretty sure that in years to come, all of you will benefit from this across various domains of research as well as other policy actions. So you all know we are very bad in our statistics. Neonatal mortality is still very high. We are ashamed to say that we are top 3 in stillbirths across the world. And maternal mortality, we are top 10. So all these figures you are aware of, and you must have come across various reports, Pakistan Demographic Survey and mortality surveys, and all those surveys. So the point to note at this time is the word survey. I would request you to park this survey word somewhere so that when I recall that word, you immediately know that the survey word was parked somewhere. So all these mortality estimates, they were, either overestimating or underestimating the mortality. You must know that, the survey is always a sample of certain population, whether you stratify in rural, urban, or whatever, though it's a sample and it gives you confidence intervals of certain population. It's never give you the exact measures. This was the presentation that I gave in Egypt in 14. So you can see the gap. All those years, when it was conceived in 2000, the Millennium Development Goals, and for 15 years, we were only relying on the surveys to see the progress. And we were very happy that we are progressing. But the reality was totally different. There was a huge gap of more than 200 deaths of mothers per 100,000 live births. And a big contribution was by Pakistan. So we then analyzed the information system that is still in place. So we had this DHIS, which is so far very primitive in some places. In some places, it has been upgraded, especially by in Punjab, they have developed the hospital information system. And we have community-based information systems like lady health workers, midwives, EPI programs. So they all go up to feed to the provinces. The gap was there was no unique identity of all those information systems that are aggregated in point in time. Sorry. Unique identity means either someone is born and you give a sign, a number, like we have CNIC, or any other unique identity which is not given to anybody else, only to that person in Pakistan. So only aggregates were flowing. There was no integration, and all decision making was not part of the process. So we come up with this study because the concept was we should not go survey. We cover each and every household in a population. For example, AJK population is 4.2 million. So we intend to cover the entire population, and the PC1 is approved. And it will start covering in 2023, July, we will initiate the process. I'm still the advisor, and on behalf of Planning Commission, I will be leading that. So the capture of entire pregnancies and the outcome was the objective. So we chose this area, study area. This boundary is Tehsil Havelian population, about 3.3 million. And it has rough terrain, mostly rural. So we then demarcated the areas where there are community workers or midwives and where there is no community worker or midwife. 20% was areas which were totally uncovered. And the same concept of survey and then this area of uncovered. So there are two words in parking now that AJK and other people in Pakistan can benefit. So basic parameters, how many were there? We had about 40,000 women that we enlisted. They were, eligible. They were married to be included in the surveillance. And, it about 79%, 17% were in community midwife areas and 4% were uncovered. There were no one over there still. So we use the existing systems because in Pakistan, the biggest problem is you introduce new systems and people are not very much adaptive to those new systems. So we use the systems which are in place and then build upon them to measure the mortality. You must have heard about a word, verbal autopsy. It's basically a tool, a questionnaire that is developed by WHO and adopted by Pakistan in 2015. It is actually a tool which gives you a probable cause of death to near certainty of less than 5% errors. We started training across all those areas. I went there, we developed poverty scores, and then focal persons of each private sector was identified. We also came to Women Medical College at that time. Dr. Chawla was there. So we trained our students to participate in the project. And this was the beautiful valley that we covered entirely. It's in Lora side, Havelian. So we did all the basic standard procedures that we know, which are, piloting the tools that we apply, test the translation, culture sensitivity, and so many things we tested and the errors were corrected. We then did the two-stage checks, randomly visiting the households and also, by looking at the data checks. So I met many women myself to actually validate the information. Data entry was done, and then we we introduce another system. Whenever there is any census or any project that intend to cover the entire population, there is always a chance of missing. So you may have known a word which is called capture recapture method. This capture recapture method was introduced in 1800 to measure the population of fish. What is this capture recapture method? This is when you put a net in a pond, you get some fish, you tag them, you throw them back, and then you again throw the net, and then you get some more fish. You will get some tagged fish into the net, whether it's one or more. Then you apply a Peterson equation, which will give you the estimated population of that pond. So this was in 1800 applied for the first time. Then it was applied in India for the census correction method. Census means you go door to door, door to door, door to door. Then another team comes and they only pick few houses to see whether the person intended to be covered in the survey is captured or not. So the second team gets another data set, and then we match those data sets using the unique identifier CNICs to see how many were mixed by the census team. So the same method we applied, and we also come up with some missing numbers, about 10%. We constituted a committee which is already there, even in AJK and Punjab and Sindh and everywhere. It's called a District Death Review Committee. But the problem was it's redundant and it needs to be revived in most of the places. The objective of the committee is to meet and discuss all the deaths that occur in a district and find out the cause, and then assign a team to rectify the cause and send the report to the provincial authorities. Unfortunately, the practice is not being done, but the structure is there. So we disseminated the seminar in Women Medical College also, and in WHO and so many places. We engaged the parliamentarians because of political change in the will, and we showed them that how much was underestimation of the mortality. Ownership was developed. We then collected the data. The results I'll quickly show you. These were the results. You can see the live births, mortality, stillbirths, they are numbers. So now we converted these numbers into rates, and then you see the surveillance system rates and the difference between these rates and the Lady Health Workers Program is enormous. There was so much underestimations or overestimations when we apply the whole of the community project or whole of the household census concept. So you see this comparison of the available data. It's this cross that you can see, and all the surveys were underestimating the mortality. Again, these are the results, and there we are. It's again underestimation in the mortality. Causes of death, mostly hemorrhage, sepsis, then aspiration, pneumonia, birth asphyxia. They were varied percentages. They deviate from the findings of the Pakistan Demographic Health Survey. Another good thing that we dig out through this methodology was that in area A and B, the comparison of mortality was such that we found a village A where there was 98% deaths due to just birth asphyxia. And there was another village B where all the deaths were due to sepsis. So the government funding was only on birth asphyxia at that time through ENC course, Essential Newborn Care course, UNICEF course. So then we argued that the impact of the course on the area where there are deaths due to birth asphyxia might be good, but it will not have any effect on the areas where there are deaths due to sepsis. So we come up with this area-specific, cause-specific intervention selection model. so that you don't waste resources. Even one village has a cause of various difference than compared to the other village. This is a union council comparison. So see, it's a wide band. There's no consistent pattern of deaths in all those areas, which means that we need to develop interventions or whatever the strategy, but it has to be area specific, cause specific. Otherwise, we will use resources unnecessarily. A lot of comparisons, a lot of differences. See, village A, B, here 6, or there only 1. So the 1 and 6 cannot have the same impact of the intervention. So we come up with the next stage. Apart from underestimation and the major causes of death that is happening in this area, so we come up with this fruit for thought that what can be done and what is the existing infrastructure. So we come up with this, the only legally acceptable platform in Pakistan is called civil registration and vital statistics. This is managed by the local government, supported by NADRA, and the only legal document accepted by the government of Pakistan is this civil registration, birth certificate issued by NADRA or local government, and death certificate issued by local government. So we then, for the understanding, we split them into 2 for your understanding. CR is one aspect and the VS, vital statistics, is another aspect. What is CR? Civil registration. VS, vital statistics. So if we have good data, civil registration, we generate good vital statistics. In civil registration, we have births, deaths, marriage, divorce, and I believe in this group, we may have someone from local government or who has worked in the local government in AJK. She was, I think, additional secretary, Dr. Kutsia. Are you there, Dr. Kutsia?
Yes, Dr. Saab, I am here.
Okay, see, that's the chunk. We worked together. She was there. Civil registration. So we these 4 events produce these rates, vital rates, mortality, fertility, growth, causes of deaths. So the missing component was planning, monitoring, and then tracking the progress for our new target, which is sustainable development goals. So we come up with strengthening of CRVS through various means. And it was known that it's a gold standard. So we applied. It's a big journey. So I would like to take you through the process of the real things that happened in Pakistan in terms of measuring the mortality. So ASCAP supported us to dig out more about vulnerable population who are most affected by underestimation of the mortalities. So there were 3 main words that you focus, apart from those that are already in parking. One was, capture, recapture method, and then there was a survey word. Now 3 more words: mainstreaming of vulnerable population, civil registration, CRVS. 1, 2, and 3. So if we can't, cover entirely due to resource issues, at least we cover vulnerable population first. These are all vulnerable people: disabled, zakat recipients, widows, orphans, homeless, nomads, displaced, ethnic minorities, transgenders, and hard to reach areas, refugees, asylum seekers, so and so. So we need to, what is mainstreaming is basically to include all these into registration practices so that we know their mortality, because they are most likely to suffer, and then we make our decisions accordingly. So the government already committed and signed a declaration, ministerial declaration. I was part of it in 2014. We did that in Bangkok. Then a decade was declared, a decade of aiming for universal registration of each and every one focusing vulnerable population, including AJK and other parts. So the first question was, to mainstream, we need data. And for data, we need civil registration, CRVS. So the issue was completeness, because most of the areas were hard, but then maybe in even AGK and other parts, there is 95% union council secretaries coverage in Pakistan. The issue was they are not registering the data of mothers, maternal deaths, any other deaths or births. So a lot of inequalities we digged out. You see these gaps in under 5 mortalities, in wealth quintiles. See this wealth quintile, the registration patterns, 6% in the lowest one, and the highest is 71, which means the births happening in poor population is already very low, and they are already vulnerable. So they are the most neglected. And these are the figures we quoted from Pakistan Demographic Health Survey. Again, rural-urban differences, Punjab, Sindh, regional variations too much, Islamabad having 71 and the KP having 11, Sindh and Balochistan, so a lot of gaps. This is the flow of the information in civil registration. Each union council is provided with a computer and is connected across the NADRA. You see the vertical connectivity over here. NADRA is connected, but the gap was union council is not giving data to the district for district planning, and then the district is not flowing information to province, and there is the gap, and also not to the nation. Only NADRA is getting benefit out of the union council birth registration. How? They sell back their data to the districts, to the provincial authorities. Am I correct, Dr. Kutsia? They are selling you, they're charging the data?
Yes, you are correct. You are right. I'm listening.
Yes. So because this was the biggest gap in Pakistan, that in 1994, when the Civil Registration Act was revised, and it was a national database at that time, the mandate was given to the local government to collect the data from union councils, but they couldn't develop their systems, and NADRA jumped in and they provided their infrastructure, computers and systems, and then they get their data regularly, and now they're giving back their data by charging money that we have or resources used on you people. So this is the biggest gap that needs to be filled, that provincials need to have their internal flow of information, births and deaths, for the accurate measurement of the mortality and any other statistics. So we come up with the mapping, and so many stakeholders are part of it, including academia. We then studied this NADRA platform, and it has its own issues. There was no cause of death, only natural and unnatural. So we then requested them, and this is the flow that they are doing, but we are not getting benefit. I mean, by me means the provincial authorities. So data topics is basically UN statistical division has certain standards that countries needs to follow. And there's a huge gap. You can see 0.000% gap, and here only 47% in terms of in various provinces. So we are basically very poor in collecting the data, whereas we have the information system in place. So then we come up with this UN Economic Commission report. It is available. I will also share this presentation with you so you can read more about this. And then the next step was to incorporate this into policies, so that the policy is made with the clear directions that what needs to be done in terms of the data for measuring the mortality. So AJK is the first province in Pakistan and the state on its own that has this concept of vertical and horizontal linkages of information system. And most of you are either known to me directly or indirectly, and some of my class fellows or juniors or seniors. So I'm very happy that you people are the leaders of the change in Pakistan. With this, I come up to the end of this presentation, and I can open the forum for any question, comments. Over to the moderator.
Dr. Rizwan, really it was very nice talk and very comprehensive talk. And we, AJK is proud of this, that we started all these things under your kind leadership. And Dr. Qudsi is also here. She is nowadays in a Zakat, director of the Zakat. And she also told me that she has worked on it. Dr. Iqbal, Professor Iqbal Dogar has asked a question. Professor Iqbal Dogar, can you ask the question? He is principal in Gujranwala Medical College. Professor Iqbal, he has asked about the mortality in the congenital malformations. What was the distribution of this? Dr. Iqbal, you can ask yourself. Professor Iqbal Dogar Saab. Okay. Rashid Saab, you can ask the question. Okay. Madam Salma Kundi, iske baad. जी. Professor Rashid Saab.
मेरी आवाज आ रही सर?
हाँ, yes, you can. Yes, Iqbal Dogar Saab.
जी. I have one question regarding the distribution of congenital anomalies in the death rates. What was the distribution of diseases, whether they were congenital vascular malformations or there were other congenital malformations, abdominal, chest? Kindly, if you can update.
Yes, it was a pertinent question. It has two answers. Number one, the project that we took was looking into the mortality only causes of the maternal deaths. But we came up with this distribution of the pattern that mostly due to hemorrhage. In terms of neonates, about 8% were due to congenital malformations. In terms of the civil registration data, in AJ&K particularly, I don't have the Pakistan figures at this time because we are focusing on AJ&K these days. It's most deaths contributing to the genetic disorders overall is 48%. Dr. Faisal was part of it, Faisal Bashir, in one of the consultation of the policy. If you recall, the figure was
Faisal Bashir is your class fellow.
Yes, he's my friend also, and my 1 year senior to me. And we were in Mirpur, and it was around 48% deaths due to genetic disorders in stillbirths in AJ&K. Rest of the data is yet to be explored. We don't have exact figure right in time with me right now.
Dr. Rashid Saab, you have raised the question.
Yes, sir. डॉक्टर जासिम अनवर बहुत अच्छा टॉपिक बड़े अच्छी तरीके से प्रेजेंट किया. क्वेश्चन तो नहीं, सजेशन कह रहे हैं जासिम साहब, क्या ये पॉसिबल है कि एक तो इसको लीगलाइज किया जाए कि इतने दिन के अंदर बर्थ रजिस्ट्रेशन करनी है और इतने दिन के अंदर डेथ रजिस्ट्रेशन करनी है और उसके बाद ये पेनल्टी होगी. और दूसरा ये कि क्या ऐसा कोई हम लिंक पब्लिक को दें कि घर बैठे एक डेथ या बर्थ के बाद विद इन 40 डेज 30 डेज ऑटोमेटिक उस ऐप से हम एंटर कर दें ताकि पब्लिक को यूनियन काउंसिल और डिस्ट्रिक्ट काउंसिल और कमिश्नर और नादरा इनके चक्कर लगाने, फीस जो भी है वो तो ज़ाहिर है वो देंगे लोग, तो कहीं ऐसा कोई एप्लीकेशन से हमें उसमें रजिस्ट्री कर दिया करें.
Dr. Jasim, really it was a question coming in mind. Still, it is difficult to get the registration of the your even deceased mother or father in Punjab.
जी, मैं बिल्कुल I totally understand and agree to the agony जो लोग गुजरते हैं to get their certificate. मैं पहले आपको इसकी legal side बताता हूँ. लीगल साइड ये कहती है कि जी आप कहीं से भी बर्थ सर्टिफिकेट ले सकते हैं किसी भी यूनियन काउंसिल से बाय लॉ. लेकिन इशू ये आता है कि लोकल गवर्नमेंट ने अपने सिस्टम्स इतने स्ट्रॉन्ग किए ही नहीं कि पंजाब में लाहौर में बैठा हुआ बंदा जो बेसिक रिहायशी राजनपुर का हो तो वो वेरिफिकेशन डायरेक्टली वहां से उठा ले. राजनपुर के दफ्तर से
On the computer,
So-
on the computer.
ऑन कंप्यूटर। तो ये चीज तो इन्होंने इसीलिए फिलहाल स्लो चल रही है कि ग्रेजुअली ये कनेक्टिविटी जब आपस में कनेक्ट करेंगे तो ये हो जाएगा। लेकिन इसमें ये किया गवर्नमेंट ने कि इन्होंने नादरा ने CRMS के नाम से ऑनलाइन CRMS बना दिया है। और अब आप जिन जगहों पे ये एप्लीकेबल है, पंजाब में बहुत सारी शहरों में और सिंध में भी हो गया है, AJK में अभी नहीं हुआ, वो किसी भी दफ्तर जाके अपना डाटा कर सकते हैं और वो कनेक्ट हो चुका है आपस में। मींस कि आप लाहौर में अगर जाएं या अगर आप इवन मुल्तान में रहते हैं और आप लाहौर के रैशी पैदाइश हुई है तो आप वहां से भी ले सकते हैं। ये तो मसला हल हो गया। अब आगे ऑनलाइन ऐप का,
Even death certificate is difficult.
सब हो गए, अब कनेक्ट हो चुके हैं। आहिस्ता आहिस्ता नेटवर्क एक्सपेंड हो रहा है। टाउन लाहौर कवर कर दिया हमने, मुल्तान कवर किए, बहावलपुर एरियाज किए हैं, अभी इस्लामाबाद सारा कवर कर दिया, बाकी एरियाज अभी कवर नहीं हुए। लेकिन सिस्टम डेवलप कर दिया है, उसकी कवरेज आहिस्ता आहिस्ता बढ़ रही है। तो दूसरा इशू ये है कि जी ऐप का, जो प्रोफेसर साहब ने कहा कि क्या हम ऐसी ऐप बना सकते हैं। यस, ये पंजाब ने एक एप्लीकेशन डेवलप की थी कि वो लोग ऑनलाइन अप्लाई करें, लेकिन उस ऐप में एक फ्लॉ आ गया था कि वो लोग तो अप्लाई कर देते थे, लेकिन वो लोकल गवर्नमेंट की कॉल उन्हें आती थी कि आप आए और वेरिफिकेशन करें कि आप ही हैं जिसने ऐप में भरा है। तो वो फ्लॉ था, वो बात तो कोई ना हुई। वो बंदा ऐप पे भर के भी और फिर दफ्तर भी जाके अंगूठा लगाता था कि जी यस मैंने ही भरी है ऐप। तो थोड़ा सा टेक्नोलॉजी का डेफिसिट था कि अगर हम ऐसी ऐप बना लेते उस वक्त पंजाब गवर्नमेंट कि जो अंगूठा उधर ही लगा के तस्दीक करती, तो फिर शायद ये मसला आसान होता। लेकिन जो प्लानिंग कमीशन जिसको मैं रिप्रेजेंट भी करता हूं ऑन सिविल रजिस्ट्रेशन और कंसल्टेंट हूं उनका, तो हमने एक अम्ब्रेला फ्रेमवर्क बना दिया है, एक लेजिस्लेशन जो अभी असेंबली में भेज दी हमने, जिसमें हमने ये कर दिया कि अब हम ईज ऑफ एक्सेस करेंगे। यानी कि एक बच्चा पैदा होता है तो वो जब पैदा हो तो ऑटोमेटिकली उसका बन जाना चाहिए, उसको जाना या अप्लाई नहीं करना होगा। इसी तरह जब डेथ हो तो ऑटोमेटिकली हॉस्पिटल के अंदर ही डेथ रजिस्टर हो जाएगी और उसको आना नहीं पड़ेगा, आपके घर के एड्रेस पे डिलीवर हो जाएगा जो शनाख्ती कार्ड में लिखा होगा। तो आई होप दिस आंसर्स योर क्वेश्चन।
There are certain other very important persons here, as Professor Zulfikar Anjum and Professor Arshad Kardedi from Bahawalpur. Professor Faisal, you have raised the question. Professor Faisal, over to you.
जी अस्सलाम वालेकुम।
अपनी
थैंक यू
शक्ल भी
सो
दिखा
मच।
देना सर, शक्ल भी मीरपुर से दिखा दे, वहाँ सर्दी कम है।
सर्दी सर आज यहाँ भी बड़ी काफी ज्यादा है, तो आई थिंक सो यू कैन सी मी।
नहीं अभी नजर नहीं आ रहा।
मेरा ख्याल है शायद कनेक्टिविटी का इशू है, फॉग की वजह से वो शायद सिग्नल्स लो होंगे, भी हो जाएगा कनेक्ट, मैंने ओके तो कर दिया है उसको। अच्छा थैंक यू सो मच जी।
Feeling problem, Shahid Khan is feeling problem of the connectivity.
जी थैंक यू सो मच सर, यू गिव मी अ चांस। अच्छा एक तो क्वेश्चन का आंसर हो गया कि हॉस्पिटल इज डायरेक्टली कनेक्टेड टू काउंसिल के भी वो ऑटोमेटिकली यहाँ से रजिस्टर हो जाए। मेरा क्वेश्चन ये है कि जो डाटा इस वक्त मार्केट में चल रहा है, जो आप लोगों के पास है AJK का या कहीं का भी, वो कितना रिलायबल है? वो कितना रिलायबल है? जो रिसोर्सेज का आपकी डिस्ट्रीब्यूशन है वो सारी इसीलिए इफेक्ट हो रही है कि अगर वो रिलायबल नहीं है, तो ये जो हम पॉलिसी की बात कर रहे हैं इसकी इम्प्लीमेंटेशन में डॉक्टर्स कहाँ लाए करेंगे फॉर रजिस्ट्रेशन ऑफ द डेथ पर्सन, और इसका काउंसलिंग सेक्शन कहाँ होगा, हॉस्पिटल्स में कितना होगा, BHUs में या यूनियन लेवल पे कितना होगा, और उनकी ट्रेनिंग का प्रोग्राम्स कैसे इम्प्लीमेंट किए जाएंगे?
जी प्रोफेसर फैसल, वेरी पर्टिनेंट एंड इम्पोर्टेंट क्वेश्चन। जो फ्रेमवर्क पॉलिसी का वो ये कहता है कि जी हॉस्पिटल में जिस भी जगह पे डेथ हो वहां का जो इंचार्ज है वो अभी भी उसका बर्थ डेथ सर्टिफिकेट बनाता है।
तेल की बोतल पड़ी है मेरे बाथरूम में, इतनी छोटी सी सर की साइड पे।
Mute your mics.
ट्रे में
ये माइक काइंडली जरा, आवाज कोई मरमर बीच में आ रही है जी। अच्छा
जी।
तो ये होगा कि आपकी डेथ सर्टिफिकेट तो अभी भी आप लोग बना रहे हैं तमाम हॉस्पिटल्स में, और बर्थ सर्टिफिकेट भी बना रहे हैं। सिर्फ एडिशनली ये होगा कि आपको प्लेटफॉर्म प्रोवाइड किया जाएगा, एक लॉगिन्स जो लोकल गवर्नमेंट की तरफ से होंगे, और आपको सिंपली वही डाटा उसमें एंटर करना पड़ेगा। दिस इज सिंपल ट्रांजिशन, उसमें ट्रेनिंग कंपोनेंट भी डाला हुआ है और हर जगह पायलट डिस्ट्रिक्ट्स भी नोटिफाई हो चुकी हैं. आई थिंक एजेके में भी 2 डिस्ट्रिक्ट्स हैं, मे बी डॉक्टर कुछ शायद बता पाए, उस वक्त एडिशनल सेक्रेटरी थी इधर.
जी मैं उसको कहता हूँ, डॉक्टर कुदसिया को टाइम देता हूँ सर प्लीज.
जी, तो ये तो एक एस्पेक्ट हो गया. दूसरा रिलायबिलिटी की आपने बात की. जो एग्जिस्टिंग सीआरवीएस का डाटा है वो डेथ का डाटा है ही 5%. तो अब 5% जो है वो रिलायबल है, क्योंकि वो बगैर शनाख्ती कार्ड के एंटर हो नहीं सकता. तो लेकिन जो बर्थ का डाटा है वो अराउंड कोई 60% के आगे पीछे है, और वो आप समझते हैं उसमें कोई एरर्स हम समझ रहे हैं कि जो
रिलायबिलिटी तक जाए.
10% का एरर मैं दूंगा, क्योंकि अभी फिलहाल आपकी लोकल गवर्नमेंट स्पेशली एजेके में वो डाटा तो डाल देती है, लेकिन वो रियल टाइम वेरिफिकेशन अभी नहीं हो रही. तो अगर गलत नंबर भी डल गया तो वो गलत ही चला जाता है, अनलेस बाद में वो सिंक्रोनाइजेशन में प्रॉब्लम आए. तो 10% एरर आपके बर्थ में है और डेथ आपकी टोटल 5% है.
Okay, Dr. Salma Kundi, before can you give me 1 minute? Can Dr. Kudsia, you want to give the comment? Dr. Kudsia? जी डॉक्टर कुदसिया, डॉक्टर कुदसिया बतूल. Okay, before this, Professor Salma Kundi, you have raised the question, madam.
Thank you, Mulazim Saab. It was an excellent talk, Dr. Jasim. We are very proud to have him in our faculty as well. Jasim, since you are implementing these policies, or you are part of it, I just want to ask a question which has nothing to do with maternal mortality. The question is, in COVID era, do you have the proper thing in place, the reporting of the corona cases? Because sometimes I have doubts. I used to compare, and either it is underreported or Pakistan has been lucky. We've had very few cases and very few deaths. So can you please shed some light on this? Thank you.
Yes, ma'am. COVID reporting, there was a special platform that we developed in Islamabad in the core committee in our command center. And that center was linked with all the provinces, और वो डेली बेस पे लेडी हेल्थ वर्कर्स की डेथ की जो रिपोर्टिंग थी वो करती थी. एजेके में हमने 7 मेंबर्स की कमेटी हर गांव में बना दी थी, जिसमें टीचर और लेडी हेल्थ वर्कर्स और वहाँ के लोकल गवर्नमेंट सेक्रेटरीज और इमाम मस्जिद थे. तो वो डेली रिपोर्ट आती थी. राजा जुल्कुरनैन हमारे जो डायरेक्टर, डिप्टी डायरेक्टर हैं लोकल गवर्नमेंट के, हमने उन्हें फोकल पर्सन बनाया था. तो वी हैड अ मैकेनिज्म, अ काइंड ऑफ एडहॉक मैकेनिज्म जो हमने इन प्लेस किया. लेकिन सिविल रजिस्ट्रेशन जो थी वो डेथ को नहीं कैप्चर कर पाई. किसी भी जगहों पे हमें ऐसा नहीं हुआ कि लोगों ने उसको डिक्लेयर किया हो कि यस ये डेथ कोविड की है, अनलेस कि वो किसी गवर्नमेंट हॉस्पिटल के किसी सर्टिफिकेट में आया हो. तो डेट वाज अ बिग गैप जो वी फेल्ट बैडली, और उसी की वजह से ये फ्रेमवर्क बनाए गए कि अब हॉस्पिटल के अंदर ही वेरीफाइड डेथ्स होंगी. वो जो भी होगा बाहर उसका डाटा रजिस्टर नहीं होगा अनलेस अनटिल कोई भी डॉक्टर उसको वेरीफाई ना करे कि ये डेथ इस वजह से है. तो दैट वाज जी. नेक्स्ट.
Okay, Dr. Zulfikar Anjam, you want to ask any question?
जी सर मेरा ये है कि मैं एज ए हेड डिपार्टमेंट पीडियाट्रिक सर्जरी भावलपुर में मैंने एक सर न्यूनेटल डेथ पे मैं एक स्टडी अपनी रादर डाटा कलेक्ट कर रहा हूँ फॉर द लास्ट 8-9 मंथ्स. उसमें मैंने परफॉर्मेंस डिजाइन किया है कि
आपकी आवाज नहीं आ रही प्रोफेसर जुल्फकार अंजम.
आई थिंक वो ड्रॉप कर गए. अभी हमारे पास डॉक्टर शाहिद शमीम साहब
शाहिद
भी
खान
हैं.
जी, डॉक्टर शाहिद, you want to जी give the comment, Dr. Shahid Khan. he was also, Shahid Khan was also feeling problem and connectivity.
जो नीट सर मेरे वार्ड में एडमिट होते हैं उनके बारे में मैंने एक डाटा कलेक्ट कर रहा हूँ उसका.
हाँ.
एक काज ऑफ डेथ और ऑन आफ्टर बर्थ कितने डेज में मेरे पास एडमिट होते हैं, किस डिजीज के साथ, एज आफ्टर ऑपरेशन की डेथ हो रही है या विदाउट ऑपरेशन. ये मेरे पास डाटा कलेक्टर. उसमें मैं जो लास्ट 4-5 मंथ्स में मैंने देखा न्यूनेटल डेथ मेरे यूनिट में लिमिटेड रिसोर्सेज है, मेरे पास 60% तक न्यूनेटल डेथ आ रही है.
In Bahawal Victoria Hospital in your unit. Okay. Okay.
So voice miss ho rahi hai.
Vice
I
President.
think
Dr.
connectivity.
Shahid Muhammad Shahid Khan. I think there is a connectivity problem. He also sent a message, sir. I am feeling.
Dr. Shahid Shamim साहब भी हैं, ज्वाइन किया हुआ है. I think he is also my university mate. हमने PhD इकट्ठी की और he is educational reforms के अंदर भी लीड कर रहे हैं. तो हमने ये गैप देखा कि कहीं भी एकेडमिक करिकुलम में जो डाटा की इम्पोर्टेंस है, स्पेशली सिविल रजिस्ट्रेशन डाटा जो बाय लॉ हमें करना है, उसका कोई कंपोनेंट मुझे नजर नहीं आया. तो मे बी ही कैन कमेंट ऑन इट कि व्हाट इज द सिचुएशन ऑन दिस.
Dr. Shahid.
हेलो, सॉरी फिर से कहिएगा. अस्सलाम वालेकुम.
Yes, Dr. Shahid, welcome.
जी मैंने थोड़ा सा वो आवाज ब्रेक कर रही थी, तो फिर से कहिएगा प्लीज.
Yes, we are hearing.
जी वो क्वेश्चन या रादर कमेंट जो मैं आपसे एक्सपेक्ट कर रहा था, वी वर टुगेदर इन सिडनी आल्सो, और आप यू आर लीडिंग so many educational reforms and modular systems. अब आप खान के साथ एसोसिएट हैं, तो we felt the need कि academics में करिकुलम में कहीं भी importance of civil registration की बात नहीं हुई. तो इस पे what do you want to say?
आई थिंक आप बिल्कुल सही कह रहे हैं सर, और मैं आपकी टॉक भी बहुत इंफॉर्मेटिव थी, और आई थिंक दिस इज सच एन इम्पोर्टेंट इशू, स्पेशली अगर हम जिस स्टेज पे अब हैं और हमारे सारे दोस्त जो यहाँ मौजूद हैं, लोग हम सब जिस स्टेज पे मौजूद हैं, इट्स वेरी सैड कि मेरे लिए भी ये इन्फॉर्मेशन बहुत बहुत नई है, बहुत न्यू है. and you're absolutely right, it should be part of the curriculum undergraduate level पे, इसलिए कि इवन जो मेडिकल ऑफिसर एक किसी डिस्ट्रिक्ट हॉस्पिटल में या शहर में या विलेज में कहीं काम कर रहा है, उन सबके लिए ये बहुत वाइटल इंफॉर्मेशन है टू बी एबल टू अंडरस्टैंड द सिचुएशन एंड वर्क ऑन इट. सो अब आई थिंक करिकुलम में जहाँ जगह बनती है इसकी, वो तो फॉरेंसिक मेडिसिन या कम्युनिटी हेल्थ साइंसेज में बनती है, लेकिन ये और इसकी जैसी और बहुत सारी चीजें ऐसी हैं जो हमारे यहाँ करिकुलम का पार्ट नहीं है और होनी चाहिए. तो आई थिंक कलेक्टिवली वी कैन फ्रॉम पीएमए प्लेटफॉर्म और अपने अपने इंस्टीट्यूट के प्लेटफॉर्म से वी कैन वर्क ऑन इट, और उसके लिए विल चाहिए सिर्फ, इसलिए कि सारी एक्सपर्टीज मौजूद हैं, लोग मौजूद हैं, आप जैसे लोग हमारे पास मौजूद हैं मुल्क में. तो अगर ये एक विल हो तो बिल्कुल किया जा सकता है, एंड इट्स सो इम्पोर्टेंट, सो वेरी इम्पोर्टेंट.
Thank you, Ji. Thank you.
Thank you so much. Professor Arshad Gardezi or Professor Muhammad Munir from Pakistan Association of Pathologists, if any person can give the comment. Before that, we conclude today's session.
Assalamu alaikum, Dr. Sahab, may I
Oh,
join?
yes, Dr. Kudsia, I was feeling that there is a problem.
I was disconnected due to the net issue. I was disconnected.
I
Sorry.
was feeling that. Yes, Dr. Kudsia Batul.
जी, एजेके में हमारा जैसे डॉक्टर साहब ने कहा कि पायलट बेसिस पे मुजफ्फराबाद, मीरपुर और पुंछ डिवीजन को लिया गया था. यूनिसेफ हमें स्पॉन्सर कर रहा है इसमें CRVS के लिए, और 2030 तक हमारा उनके साथ एग्रीमेंट है यूनिसेफ के साथ. और इसमें हमने जो की एरियाज थे सिर्फ मुजफ्फराबाद, मीरपुर और पुंछ को, डिवीजन तो पूरे आते हैं लेकिन मैन ये डिस्ट्रिक्ट 3 कवर हुए उस प्रोजेक्ट के अंदर. और अभी तक हमारी जो टारगेट है 2022 में जो हमारा टारगेट था बाथ रजिस्ट्रेशन का, वो 1,75,000 और था टारगेट, और 1,25,000 रजिस्टर्ड हो गई. लेकिन अभी तक जो रजिस्टर्ड हुई हैं 2022 तक जो बर्थ रजिस्टर्ड हुई हैं वो 2.5 लाख हैं, 2,50,000, और डेथ्स रजिस्टर्ड हुई हैं 49,000. तो अभी तक का ये डाटा यूनिसेफ के साथ 2030 तक हमारा ये चल रहा है. लेकिन यहाँ मैं एक बात ऐड करूंगी, डॉक्टर जासिम भी सुन रहे हैं, कि जब मैं लोकल गवर्नमेंट में थी तो हमने जब इस पे बड़ी मल्टीपल वर्कशॉप्स हुई और कंसल्टेशन हुई CRVS रिफॉर्म बिल पे, जो फेडरल ने ड्राफ्ट किया था, और मैंने AJK के लिए भी बिल ड्राफ्ट कर दिया था. CRVS रिफॉर्म बिल जो मल्टी सेक्टोरल अप्रोच है, जिसमें हेल्थ डिपार्टमेंट, एजुकेशन, लोकल गवर्नमेंट, IT यानी ये उनके रोल डिफाइन हैं उस बिल के अंदर, और वो बिल मैंने बना दिया था, फिर मैं ट्रांसफर हो गई। आई डोंट नो व्हाट्स द स्टेटस ऑफ दैट बिल। लेकिन अगर वो बिल हो जाता है तो फिर क्योंकि शुरू में तो ये था कि नादरा भी कोऑपरेट नहीं कर रहे थे हमारे साथ उसको लिंक करने में, तो नादरा के साथ तो चल रहा था, लेकिन जब तक नादरा के साथ हम इंटीग्रेट सिस्टम में नहीं होते, ऑनलाइन फिजिबल नहीं है। लेकिन ये है कि जब वो सीआरबीएस रिफॉर्म बिल में ऑनलाइन रजिस्ट्रेशन और सारे मैकेनिज्म उसमें डिफाइन हैं, ये नेशनल लेवल पे ये कंसल्टेशन हुई थी, फेडरल ने ये बिल इंट्रोड्यूस कराया, फिर सूबों में भी अभी उस पे हो रही हैं, लेकिन एजेके के लिए मैंने वो बिल बना दिया था। अगर उसको भी हम किसी मौके पर कोई डिस्कशन हो जाए लोकल गवर्नमेंट के सेक्रेटरी के साथ, तो वो मिल बैठ के एजुकेशन, हेल्थ डिपार्टमेंट और लोकल गवर्नमेंट बहुत अच्छा वो उस पे कर सकते हैं, और
Local government
सीआरबीएस की
secretary is very,
इम्प्लीमेंटेशन में
very
इफेक्टिव हो।
Professor
जी
Dr. Qudsi Batul, local government secretary is now Shahid Saab.
जी
Shahid Mike Saab, he is
या
very vigilant. I
या
think with you, inshallah, and for Jasim, will go to him and to proceed it.
जी
Okay,
श्योर।
if anybody has no question, I hand it over to today's session to conclude. Professor Sarmakundi.
Thank you, Professor Mulazim Saab. I can see Dr. Qazi Wasik Saab here as well.
Qazi
Dr.
Wasik
Qazi
Saab is
Saab.
there. Qazi
Yeah,
Wasik
he's
Saab.
here.
Dr.
Hello.
Saab.
So he is our president of SEMAO as
Uh,
well, which is PMA is a part of SEMAO.
Qazi Wasik Saab.
Sir, thank you very much. It's really wonderful to be a part of this very important topic. Thank you, Dr. Jasim, for wonderful and very informative presentation. I think बहुत सी बातें डिस्कस हुई, और जैसे कि आपने ये CRVS और इसके बारे में बताया, और इससे जो आइडेंटिफाई हुए गैप्स और फिर जो चैलेंजेस हम फेस कर रहे हैं, आई थिंक इसके लिए काउंटर चेक्स और बहुत सी चीजें आपने यू हैव पॉइंटेड आउट, और मैं समझता हूं कि हमारे डॉक्टर्स को इसकी अहमियत का अंदाजा ही नहीं है कि ये डाटा कलेक्शन और ये जो स्टैट्स हैं वो हमारे लिए कितनी अहम हैं। और जैसे शायद शमीम ने कहा कि ये करिकुलम में ऐड ऑन होना चाहिए, और आपकी ये पायलट स्टडीज जो हैं मेरा ख्याल है कि पाकिस्तान के लिए बहुत ही अहम हैं, और हम उनसे बहुत कुछ लर्न करते हुए आगे जाएंगे, और इसलिए कि हमारा डाटा हकीकत में बिल्कुल रिलायबल नहीं है, और जब हम अपनी डेमोग्राफी देखते हैं तो उसमें बहुत सी चीजें मिसिंग होती हैं। तो आई थिंक इट वाज अ वंडरफुल टॉपिक और वेरी नाइसली कवर्ड बाय डॉक्टर जासिम, एंड थैंक यू वेरी मच, एंड आई थिंक इस पे और मजीद बात होती रहेगी। यू हैव ओपन दीज आर द यू नो यू हैव क्रिएटेड ट्रूथ फॉर थॉट्स, और लोगों में डिस्कशन आना है, और इसको बहुत ही रिलायबल बनना है विद द काउंटर चेक्स वेरिफिकेशन सिस्टम।
Dr. Basim, you want to give the question? Jasim, you want to give the question?
Yes, thank you so much, sir, for the encouragement, and a lot needs to be done. Is forum ka benefit lete hue, I would request another important session that we started last month. It's making the national blood transfusion policy. So I am engaged now with the federal government. So हम केपी में चले गए हैं, केपी में हमने कर लिया वर्कशॉप और एनालिसिस तो ब्लड ट्रांसफ्यूजन issues और उसके ऊपर जो policy guidelines है, तो maybe PMA can be a good forum to give their inputs on this national policy. So इसका process जो है 5-6 weeks चलेगा. Now after that हम बलूचिस्तान जा रहे हैं, फिर सिंध and पंजाब, and then GB AJK, और फिर मार्च में national consultations in federal government कर रहे हैं. So you can host a seminar on the national blood policy on working day preferably, or so I'll be happy to get your inputs on that as well.
Also, Dr. Jasim, very good suggestion. I think the continuity of this platform We can hold online seminar next week, next Sunday, and with this continuity, hopefully it will be very fruitful. Dr. Qazi Saab, can you comment or we conclude through Professor Salma Kundi? Professor Salma Kundi?
Okay, Jay. Thank you, Professor Mulazim Saab. Thank you for being our moderator and conducting this series of webinars. And I thank the PMA. And I thank Qazi Saab for being here. And I thank all the organizations which are endorsing us, like your Pathological Society and My Physiological Society and our medical colleges. Jasim, it was an excellent talk. I'm very, very grateful to you. And I hope we continue on the blood transfusion policies. Probably next Sunday is taken by an international speaker. The one after that, or even during
Professor
the
Salma
working
Kundi,
day.
अगर
Dr.
weekdays पे रखें तो उसमें we can get more audience पूरे national level पे. Sundays को लोग probably committed भी होते हैं, तो I don't know if possible.
Okay, because I think we will advertise it. So we will start advertising since Monday, and we have 7 days in advertisement. And Professor Salman Kundi, the international speaker from USA, Professor Sarwat will speak on 21 or 22nd. That is artificial intelligence. He also talked this in King Edward Medical University Symposium, and we requested him because nowadays the artificial intelligence is getting more and more importance in information technology. Dr. Jasim Saab, if you suggest कि हम इसको क्योंकि हमारे लिए पॉसिबल ये नहीं होता कि हम संडे का एक लेट्स गिव suggestion and Professor Salma Kundi will discuss this. Is it possible for us to conduct this on any working days? कभी हमने किया नहीं है,
Actually,
कभी
you know
किया
very
नहीं।
well the SEMAO meeting is on Saturday in the morning, and it's becoming a failure because all of us are busy at that time. You know,
Yes, yes, yes.
during the work time, it's busy unless we hold it at some evening time.
Dr.
So
Jasim,
we
not only we are here, so many people are sitting in on one topic and they are, and we also share this on our website, and I think
You are
most
right. Actually, what we can do is actually we have other forums as well. We have Australian scholarship forums, university forums. We have
we
a
can
Harvard
share this. We can
consortium.
share this.
But the problem is, all over the world, including myself, I never. It's because she's my principal also, or my teacher and my family member. You can say, Dr. Salma. I can't refuse her to be on Sunday. But normally I